Present to you the Pobanz Pearl Jam 2025. I'd like to thank all the folks over there that have afforded me this opportunity to share some of my ideas and thoughts about clinical orthodontics. It's been a lot of years that I've intended to contribute to that knowledge base, and I'm grateful to do it tonight as well. It is actually November 30th for me after a Thanksgiving weekend, getting ready to dive into the month of December with all of you. Update on my family. I've got 6 grandkids now. We celebrated my 56th birthday there on the beach of Lake Tahoe in the month of August, late August this year. Having a lot of fun with the grandkids. Doing some faculty adjunct volunteer teaching at Roseman, and really enjoying that too. My wife Angela and I have celebrated our 10-year anniversary, second marriage for both of us, and continue to thrive. She's a clinical psychologist. As the team, photo from a little while ago, Dr. Tuttle has moved on to his own practice in Central Utah, and I've got Dr. James Martineau with me right now. He's getting ready to do his own startup too. I really enjoy having young, energetic orthodontists join my practice, contribute to it, mentor them, and then have them really succeed on their own. And this will be the 3rd time around for us in that effort, and it's been an awesome process to experience that. Dr. Tom Pitts has been my mentor probably since about 2003 is when we met. I went over there to learn about self-ligation in Reno and got to be friends with his son as well. Arnie's a close, dear friend, and we've collaborated and helped each other in many ways over the years. Kind of moved away from using Damon brackets to the H4 system with OrthoClassic, and then that's evolved into the Pitts 21 system. So thanks to Tom and all of his great mentoring, many people can say that. He's had just a huge, deep and wide impact on many, many people. So those years of volunteer teaching were by invitation at Pacific, then UNLV, now Roseman. It's been a great ride. My role has been mostly to add auxiliaries like mini screw anchorage to the Pitts 21 system, as well as other auxiliaries to help bridge the gap between really great patient compliance and or patient biological response to the existing protocols that have been developed. A think tank of many, many folks have contributed to that under Tom's leadership. And sometimes we get a great outcome in a short amount of time. Sometimes we need more things to get there. To help map that progression. Since 1998, when I finished school, now 27, coming up on 28 years. Wow, that seems like a long time. 98 to 2002, MBT, taking out a lot of teeth, 24 visits to treat a case in an 018 slot. But that 018 slot experience for me had tremendous value. Then a 10-year run with Damon, got it down to 19, but like a lot of us, I just had a hard time finishing cases, and anterior rotations were a big struggle. I think over time I've gotten better at putting brackets on too. The H4 slot depth reduction made a big improvement to 15 visits per case. And then from 2018 onward, we got it down to 13.2 visits. I did a comparison with Norris 2026 and showed about a 3 visit per case savings. For me, it was hard to visualize how to put the Norris brackets on. I think because my eyes were trained to the H4, and then the light forces of 2020 wires, 1919 wires, it just sold it to me. And I've just stuck with it ever since. 21 to 23, all the way down to 12.8 visits. And that's just with the single doctor. We had a lot of growth post-pandemic. And I added some associate doctors back to back, one and then another. And with growth and with associates, cases go longer. And a lot of it's just chair-side clinical decision making. But I think going forward now in 2025, to get that back down into the 13s or even the 12s, I think the DIBS indirect bonding system makes a lot of sense. So we've got a certain percentage of cases going, dabbling, implementing, trying to overcome obstacles. Those other clinicians out there that are showing great results with DIBS, I admire what they're doing with that and following it and implementing it in my own way. But I think that's going to be great for calibrating across doctors. I think it's going to be great for custom torques, especially on posterior teeth, lower molars especially, that tend to end up in posterior crossbite that require toe-in bends. I think a lot of that's going to go away with custom basing as we continue to evolve and then leverage the artificial intelligence predicted view of what we can see with full arch wire torque expression and the broad plus arch form, right? All those things come into play. So that's just a progression of things over 28 years for me as a clinician. Had a great appreciation for the prescription of the bracket system and a little bit of input on that along the way. Not a tremendous amount in that regard. That's really Tom's brainchild. And I think some of the things I've been a advocate for would be self-ligating sixes. So I know that's in the process of being studied and looked at and beta tested. I'm also a big fan of maybe more negative crown torque on lower sevens, but if DIBS with custom basing bridges that gap, good things would happen. You can see right here in the central incisor area, we got a plus 12 degree torque bracket. And one of the things I've become really excited about is, full engagement of the 2020 wire, full expression, and then be able to turn off the torque in a 1919. I think we are seeing consistent accuracies that we never saw before over these last 7 years. So one of the things that can happen is in the way of a pearl is the 12 degree root rescue bracket. If we look at these really irregular transposed canine first bicuspids, and we have that central incisor bracket at our disposal, we can be thinking about pivoting and using that as a tool to take root torque where it needs to go. So these first bicuspids that have irregular root torque, if I take an inverted central incisor bracket and then work my way through 1818 and 2020 NiTi, in a very short amount of time, root torque expression will happen. That 2020 NiTi, those who haven't tried this, if you ever have a stray root, maybe you have an incorrect base where you didn't adapt the bracket adequately to the tooth and there's extraneous material in there giving you incorrect torque expression. This is one way to recover it. That's kind of a common thing in the lower incisor area, right? We go down there and feel for root prominence and eventually determine that, gosh, I need to direct that root somewhere else. An upper central incisor bracket can do that for you very consistently. Another pearl that I've been excited about is take a crowded arch like this and see these blocked out canines, and we're inverting upper incisor brackets. And maybe it's not just on centrals, but also laterals. There's so much torque control. I think there's a little typo in this image. I don't think I'd put minus 12 on the laterals. So just keep that at minus 8. Just invert 2 to 2. And place our active coil spring from 2s to there we go. Let me play that. Yeah, to 4s to open room for the canines. And then, bring those canines down into place per usual. But once we get the canines in place, you can see the torque control of that anterior segment is beautiful, right? Those really aren't flared. We don't see prominent lingual cinguli. And now we all know that a long span coil does a better job at opening big space rather than a short span coil. That's, even Damon Mechanics 101, right? So intentionally not putting a bracket on that upper right first bicuspid is the story. But then a bonded tether, if you look at that, it's a piece of ligature wire from the 3 to the 4 that's bonded to the facial surface of the 4 with the intent that as the space opens from 6 to 3, the 4 is held in interproximal contact with the 3, preferentially creating space for the blocked out 5. Right there. And then, of course, once there's room for that 5 to come in, we take that same negative 12 degree central incisor bracket inverted from plus 12 to minus 12 to drive that root labial into the arch and into correct torque position. So there's that really crazy crowding pattern. Everyday mechanics to use inverted upper incisor brackets, bring the canines into the arch, tether the 4 against the 3 with a long span coil, and then direct the root of the 5 into its final place. And again, great distalization, great torque control, great arch development without flaring incisors. This is what the power of the torque of the Pitts bracket system. And Pitts 21, I just don't see myself being able to achieve these same changes with something else. So a couple of marketing pearls that are fun. Branded 1967 VW bus. I found this, decided to do some work on it, and then also brand it. This is one of those fun things that people turn and smile. I'm at stoplights and people grin. There's a lot of wrapped vehicles out there, but maybe think about a vintage vehicle that resonates for you. We take this to parades. We take it to community events. People stand by it and pose for photos at our appreciation events, etc. But this has been a lot of fun. Another fun thing is we really like to showcase existing or former patients of the practice. So one of the unique things is we actually have 2 former patients from Ogden, Utah, that are in Los Angeles now as part of a boy band called the Full Circle Boys. And Dawson Bell, isn't that a cool name? Sounds like a boy band name. And Jagger Moon, even more cool, right? These cool names of these teenage fellas, well, probably young 20-somethings now, with great smiles. Jagger's not showing his teeth there, but he's showing them here. And put that actual patient on a billboard and then park that billboard close to wherever they went to high school, wherever they grew up. And what's really fun is to see the engagement that this achieves as people see Jagger. And of course, we did a spin on Move Like Jagger and called it Smile Like Jagger. And this got a lot of traction. People were really excited about this in Ogden, Utah. Okay, back to some clinical thinking. Dr. Mark Unoski, credited with these images, really helped me understand tooth emergence and this process of active eruption that we all appreciate as teeth erupt and that little rocket engine of that open apices of incisors or any other teeth for that matter creates this amazing biological phenomenon of eruption of teeth to the point that the CEJ then is exposed above the alveolar bone. And then there's this passive eruption where the alveolus and the gingival margins remodel over time with age, right? And then from there, that 1 to 2 millimeter change is established. Active eruption is complete, passive eruption is ongoing, and vertical alveolar growth then changes vertical position of teeth, right? The whole alveolus changes. And we know that this is important for us to understand as orthodontists because we're often treatment planning or co-treatment planning implant placement. And we've all seen implants placed earlier on the growth continuum than ideal that result in infraocclusion, compromised aesthetics and function of the classic lateral incisor anterior aesthetic dental implant. So that's everyday stuff. We're doing that as orthodontists all the time. But it just brings up this question, does growth ever really cease? And does vertical change of the maxilla ever change? And really the answer, based upon all these studies from some of the biggest names in our specialty, is no. The vertical alveolus, or the alveolar process, vertically changes continually over time. Some citations, right, that further give clarity in this regard. Some famous literature from Rolf Behrens. And ultimately, I think the everyday doc in the trenches can just understand that even after 18 in the girl, or even 21 in the young adult male, we're going to see vertical change of the maxilla at a rate of 0.1 millimeter per year. So that implant crown that's in infraocclusion is probably somewhere close to a millimeter of change over a decade. And that, some patients end up replacing crowns on implants at that rate. Every 10 years, if they don't like that step, they get a new crown, and then they get longer and longer in the tooth. And of course, that has its own aesthetic compromises over time. So I'm a big fan of avoiding implants in the aesthetic zone. But this has become now relevant to gummy smile management and full arch intrusion. This is a famous case, originally treated in 2007. Oh my gosh, right? I'd seen some cases shown in Europe, Jay Bowman, and this is kind of a famous one that I wrote up. We treated, and this young 13-year-old, and by the time it made it to Orthotown, it was 2010, and it attracted a ton of attention. And Stuart Frost and John Graham got excited, and Ed Lynn from Milwaukee, and we were collaborating, and of course Jay Bowman was excited, and everybody in those days was tad crazy, and it was so much fun to see that evolve. And this case, is one that was celebrated and talked about and used as a reference. And even to this day, Stuart Frost shows it his Gummy Smile course, I think at the beginning, and talks about how it inspired him to really take the protocol and evolve with it and change it. But interesting to think about, if the maxilla changes at a rate of at least 0.1 millimeter per year, what would this look like this many years later at age 30? Ba-boom. Wow, I don't think anybody expected that. The same patient showing now a return of gummy smile display. And, sometimes gummy smile cases are deceiving because the patient smiles a lot or a little. But in this case, I think it's a pretty consistent amount of animation going on with upper lip. And, I saw her in retention. We're treating a daughter. She's 30 years old. Got a bunch of cute little kids now in the practice. And if you practice long enough, you're always going to see some things emerge, just like all those open bites that don't seem to want to stay closed. Gummy smiles, if treated too early, can come back. And I'm working on a JCO write-up of this. First time I really publicly talked about it outside of some groups, but the Ceph superimposition definitely shows a significant change to the maxilla between the ages of 17 and 30. Downward and forward. And there's a skeletal component and a certain amount of dentoalveolar change or dental change, but not so much. It's a lot of just maxillary downward forward change. Maybe more than the average person even. Maybe it's more than 0.1 per year. So, lessons. Perhaps we should delay TAD-assisted intrusion for vertical maxillary excess until growth is complete. Maybe that patient that's really asking for it just needs to be educated that, okay, we can do it now, and we're going to finish this at 15, but I can't promise you what it's going to look like when you're 25. We might need to refine it, and I'll show you how I refined this one. But their timing of intervention justifies more long-term study and case comparisons with collaboration. I think there are a lot of gummy smiles that have been treated now over the last 18 years, 19, even 20 years. But we probably should just be explaining to patients that it may not be constant over time and that their upper lip tonicity will change. We know that that's going to become less active, and that as the lip drape changes vertically, it may keep pace with the dentoalveolar vertical change, or it may not. And I think the later and longer we delay that, probably the less amount of recurrent gingival display we will see. So just if you don't believe me, I'm tracking another case. It's been a 10-year story from 15 to 25 where a certain amount of gingival display is returning in that case. But then back to her, Miss Mariah. Over the last year, I said, well, let's fix this for you. But she didn't want to have braces. She's a professional and she's working in a busy career and managing kids. And so what did I do? I used aligners, played around with a lot of different protocols for this over the years, but I've come to the conclusion that it's really hard to wear aligners and 4 elastics, but it's reasonable to wear aligners and 2 elastics. These are 1.4 by 7 millimeter Super Tad. Oh, I'll go back. Super Tad is my collection of BioArray Tads. I love 1.4 by 7 for interradicular Tad placement. Notice that I've supported the anterior teeth with a bonded wire. I've also asked for the gingival margin to be cut out around that bonded wire. That's to control torque during the intrusion. And those power chains in the front, placed on a V, are really convenient and easy. The sweet spot for posterior en-masse intrusion over an aligner, whether for open bite or for gummy smile, is a 5/16 8-ounce elastic. I think that Diego Pedro really touts that strength and size of elastic. But these Tads in this location, 2x14 Super Tad by BioArray, stainless steel Tads. And I put one between a 6 and a 7 on one side and one between the 5 and the 6 because I was just kind of interested in testing whether it made a difference. And then, of course, the buccal Tads are high infrazygomatic crest Tads that are 2x12s placed just mesial to the mesial buccal root of the upper second molar and on a good bite and bend angle so as to allow intrusion without interference and collision. So I got some turbos, built into the aligners, and I got some cutouts, and you can kind of see how the aligners engage. We've got some posterior intrusion in the ClinCheck. I think I actually sent this one to Angel just to play around with that platform. But yeah, we get some nice intrusion, we get some auto rotation, and she gets that awesome change to her gummy smile. So that's your way to recover 10, 15 years down the road when the gummy smile returns if you treated it too early. Support the upper incisors with a bonded wire and use liners, and maybe try to do it with just 2 elastics rather than more than that. So yeah, BioArray mini screws are very popular. It's kind of hit the market in Taiwan back in the early 2000s. Dr. John Lin, Chris Chang then created the orthobone screw, which is very similar to it, but it's a copy of it. And then from there, it came to the United States by way of Patricia Vergara, who asked me to be a distributor clear back in 2012. So for a period of about 6-7 years, I distributed BioArray screws, and I created my own curated system or selection that I called Super Tad, and I distributed that. I no longer have a financial interest in the system, but what I've noticed is it's hard to get, and it's hard to get at a good price point. And paying for shipping all the way from Europe is a bit of an obstacle. Waiting for shipping from Europe is an obstacle. And even the distribution in Florida has been found to be a little hit and miss in terms of service. So as a result, I got excited about the idea of BioArray being more accessible. And I approached Cottonwood Lab right here in Salt Lake City on a collaboration for MARPI. And at first, the idea was, hey, let's just use Super Tads in combination with MARPI because they're 2 millimeters in diameter. They have square heads. They don't fracture. They don't strip. And it's evolved into something significantly more over the last 15 months. So I'll touch on that more, but let's look at some gummy smile cases from the Roseman Clinic where I'm an instructor. Dr. Hunter Pitts was working on Dr. Amy Blazajewski. I hope I pronounced that correctly. She's a sweetie. And She only wanted a certain amount of gummy smile change, but that was awesome. And then Dr. Derek Bush treated his lovely wife with the same protocol. And then lastly, Dr. Della, as his patient, Ryan Howard was the student clinician working with me on this case. We applied the gummy smile protocol to all of them, but we have some updates. These are the pearls for gummy smile bonded TPA. I'm a big fan of just controlling torque. Maybe call me a control freak, but I just don't want teeth to flare buckle. And I don't want to rely on squeeze exercises to control that. So in my hands, full dimension arch wire, inverted upper incisor brackets, 2x14 TADs between 6s and 5s, a bonded TPA made out of 036 stainless steel with a little omega loop that I can adjust. I can cut that mesh and acrylic out of there and adjust it, put it back on, flow TKO in that area as a replacement. I can remake it if I have to, but I don't have to worry about bands and separators. That occlusal wire is just 1925 stainless steel that's been laser welded at that junction on the occlusal of the 6. But this is my go-to bonded TPA these days. Works really well. Of course, you fabricate it with clearance relative to the palatal tissue. And those reliable 2x14 TADs are wonderful to go through the tissue, transcend through that concavity where the greater palatine nerve, artery, and vein live, and engage bone without overgrowth. They got a beautiful tissue collar on the BioRay Super TAD screws to prevent that. Of course, in the anterior, 1.4/7, 1.4 is just narrow enough to go interradicular and just long enough to pick up a portion of the lingual cortical plate. Took a bunch of years of trial and error to come up with that dimension, but it's my go-to interradicular TAD. Of course, we're activating and controlling proclination with a leash, and when activating the anterior segment, less is more. It only takes 115 grams, and activate the posterior heavily. Be aggressive back there on those TADs because you've got all that surface area. Each of those maxillary molars has 3 roots on it. Takes a ton of force to intrude those consistently. That's why I really like the TPA. As I load up that force, we never get any buccal inclination or lingual inclination. And then the anterior, we're leashing. And of course, I like my TADs between 3s and 2s. So this is a DIBS case, and on the outset, it's like, wow, there's just not enough smile arc. So we get Dr. Della in the chair, and we're looking at it and saying, wow, we've intruded really nicely from where we started, but it's looking a little flat. And there's a certain amount of gum display, but there's also yards and yards of keratinized tissue, right? So let's pull up and let's do a mid-treatment gingivectomy with my SpectraLase laser. Thanks you, Bob Cobley, for your awesome device. It's wonderful to pause, get tissue out of the way, and then reposition 2 to 2, 3 to 3, or even 4 to 4. You usually don't have to reposition 6, 7 to 7, but that anterior segment can be modified and adapted to the needs of the patient to dial in what we're looking for. So a mid-treatment gingivectomy and smile arc protection assessment on this case. And that middle photo to the end photo is just a 4-week expression of 20/20 NiTi after it's inserted, getting us some really nice smile arc and occlusal plane change, and even managing what seems to be like a little bit of an open bite. So the open bite closes because we get more anterior intrusion than posterior, but then I'm looking at it and saying, gosh, all we need to do is get the tissue out of the way and put those brackets up a little higher, and we're going to get exactly what we're looking for. And of course, Dr. Della is amazingly photogenic and took some really great images here. And then from pre to post, full debond. Shout out to Hilton Goldrich down there in Plano, Texas, helping us with the final photo. She gets a great gummy smile change. So efficiencies. Maybe we want to delay to early adulthood with gummy smile correction. We want to invert our upper 2 to 2 brackets to prevent proclination. We want to use a bonded TPA with the right TADs. We want to leash 6 to 6, running our chain incisal to the brackets 2 to 2. Less force application is more in the front, and more is more in the back because of root structure and root surface area. And a mid-treatment or even pre-treatment gingivectomy of a lot of excess keratinized tissue makes a lot of sense. And then manage smile arc right from the very beginning. Maybe if I was bringing my A game, I would have recognized that even in my dib setup, I could have exaggerated smile arc, anticipating the intrusion of that case. All right, so back to Super Tad. We came out with these 2x14 and 2x17 Tads with a smooth neck years ago. Patricia Vergara out of Colombia said, hey, we need something that we can put in the IZC that has is friendly to the soft tissue mucosa. So that was the origin. The 1.47 Tad we talked about going intraradicular, and the 1.5x8 with the slot in the head we use for our Y bars and our T bars. And ultimately, this system of stainless steel just has so much versatility to it. I have no financial interest in the system anymore, but I am a speaker also for Cottonwood Lab. So what a lot of people wonder is, hey, what do I do with all these instruments from different systems? If you're going to use BioRay, these are the instruments you need. But interestingly, the ortho bone screw drivers, right, that regular long blade is compatible. That rotatable handleable from ortho bone screw is compatible. Why? Because they're both made in Taipei, Taiwan, and one's a copy of the other. The BioRay is the original. The ortho bone screw is the copy. Have your opinion about that as you wish, but that is the truth. The nice thing about BioRay stainless steel is it comes from a raw material from Sweden. And I've yet to see any other stainless steel screw anywhere, including knockoffs made in China, that performs better. Now we've got a ratch wrench adapter for completing our Marpy insertions, which is amazingly helpful. And then everybody needs an orthonia or a torque driver, along with these blade for engine drivers to fit into the contra angle and reach deep areas of the palate. Now that we're working in a world of Marpy mechanics and adding Marpy to our repertoire to treat narrow vaults and palates, posterior cross bites, and now even airway struggles of nasal breathing in patients of all ages. So I've just always talked about the penetration of the cortex, the buccal shelf, fracture resistance, ease of insertion, and the 2 millimeter diameter that will not really fracture at all under any normal circumstance, including Marpy. So there is a hands-on course being offered in Salt Lake City Friday, September 11th. If you're interested in that, this is a TADS 101, right? Those that didn't really do much of it, or did it for a while and retreated from it, or have had difficulty, or they've been to some other courses and couldn't make it work. I'm getting great feedback from different people that this was really helpful to them. We have a anatomical model and a pig cadaver head exercise so that you really come away from this one-day experience feeling more ready to do more TADs. And I can prioritize for you what I think are probably the top three. Marpy, buccal shelf, and Y-bar for upper molar protraction are really the big ones. That's Eddie the Yeti. He's showing there up there at Weber High at my alma mater at a football game, because we're doing what we call the punt, pass, kick, where me and the student body officers are going head to head from the goal line, first to kick it, then to throw it, then to punt it for the most yards. And this video is kind of fun. There's the kick. Oh, yeah, that's me getting it to the 50. And there's Eddie making his way down there. And ultimately, I wager that I'm going to lose, or that the winner, I should say, gets a donation to the football team, and I always lose on purpose. So that's how that goes. But that's a fun thing to do. Approach your local high school and do a punt, pass, kick, and maybe get a mascot to show up too. All right, so we're digging into Marpy, the evolution of things since 2017 and Juan Moon's MSc. We look at that appliance on the left-hand side and say, oh my gosh, why were we ever putting TADs in that far back when we've known since 2007 that we have beautiful islands of bone adjacent to the first bicuspids in the palate? And we had so many failures, asymmetric expansions, tissue impingement with the Moon device, but it got us going in the right direction to start thinking about what we need to think. But those areas of yellow and green in the palate have long been shown to be areas of adequate and reliable retention. And now we have 3D custom devices. And you can see that we're leveraging that. CBCT merged with regular STL files, gives us the ability to now customize length, size, position of TADs. And the BMK TADs came out with 1.8 millimeter diameter, and we just defaulted to that because that's what we got with our MSE kit. But now we're realizing that, wow, we can use 2 millimeter stainless steel screws that have those smooth necks on them and be even more successful and avoid even less complications. Plus, the Tiger screw is a game changer. Came out of Austria, and it's stiff enough to allow us to make the change. So all these components from all over the world, think tank of people. I've been following them from the very beginning. I went to Dr. Evans' first TAD-supported Slick Van Arsdale version of a MSE, which is acrylic on the kind of like a Haas, supported by lateral TADs. Really cool concept. And then we watched as we evolved into the MSE, and Dr. Ting in Southern California went to his course, and he was talking about, hey, maybe we need to do a piezo incision. And then in 2024, I realized that Ting and Lipkin, Dr. Ilya Lipkin out in New Jersey, outside of New York, were classmates at NYU and had been collaborating the whole time. And now this whole era of 3D custom Marpies, with and without piezo, perhaps a more controversial treatment method for especially adult males, but in my hands, I've decided to adopt that, and it's serving me well. And now I'm in the middle of Dr. Audrey Yoon's online airway fellowship, and incorporating the no diastema protocol that was kind of made popular for the first time last April, right? We're talking 8 months of public knowledge and sharing. And now, I really feel like the teacher of the teachers is probably Dr. Lipkin, but the others are neck and neck, right? Everybody's adopting little versions of their own protocols. It's a fascinating time to be involved in orthodontics, and Dr. Ilya is right there at the tip of the spear, probably helping most of us gain the right knowledge. This is an old flyer, but he has an ongoing offering on his website. I think he's offering it every 6 months. I highly recommend this great in-office course. I don't really consider myself a Marpy instructor, not quite qualified, but these folks are the ones that are doing hundreds of cases, including Richard Robley in Arkansas. So in 2026, it's a priority for me to go and learn his no diastema protocol, controlling the anterior diastema, and also augmenting cases with SFOT of the lower arch to make sure that we're not compromising the lower periodontium as we try to make the lower match the upper. So some cool images. Elsa Arango created that image there on the lower left. She's also an amazing clinician out of Colombia. Some just incredible TAD people all over the world that I've gotten to know. Dr. Ludwig made that drawing for the JCO in the upper left, clear back in 2008. But we're seeing, that's where we put our TADs. And this is a custom 3D with BMK TADs. And then now we've got custom Marpy with diastema and BioRay TADs at 2 millimeter diameter. And we got male designs with 8 TADs, and we have female designs with 6 TADs. And less are we relying on the posterior mid-palate because it just has less bone stock, right? Now we know because we're seeing CBCT. And we're getting TAD maps from different labs, including partners. And now we got other labs in the space. Really, 3D custom Marpies should be something that most labs can offer because everybody offers a Herbst. And we need options. We need geography and proximity. We need short turnaround times. And we need cost control. And everybody forms their preferences and their trust level. But I've gone down this road on a bunch of cases. And one of the things I found that was a struggle was controlling the tiger screws, both in the yaw relationship and the roll relationship. And as it is, unless that's perfectly 90 degrees to the mid-palatal suture, you will introduce yaw and an unusual expansion pattern. In this particular case, the upper left quadrant traveled to the patient's right and causing the midline to deviate to the right of his nasal tip. And it's become an ongoing challenge to manage that. You can see where it is, and you can see where it is here with improvement, but all kinds of creative things, hybridized brackets, upper aligners for distalization, TAD support. But I look back on those struggles and say to myself, gosh, if I'd just been more attentive to tiger screw orientation. A friend, I won't share names or the lab or anything, also went down a road where he noticed that this patient had a cant. And he specifically asked the lab to orient the tiger screw opposite the cant to the tune of 1 degree for every 2 millimeters of vertical change. And as it went, a mistake happened and it was oriented the opposite way. So it actually made the cant worse during expansion, right? That right side of the maxilla dropped vertically. And now this patient is going to have to go through a certain amount of TAD mechanics to recover that. And we're seeing that big diastema and that flat papilla and also those divergent central incisor roots. And we're saying, wow, it's going to be okay, but maybe there are better protocols to follow to avoid some of these things, especially during the fabrication process of the MARPI itself. So as I've studied some of these challenging situations, and I haven't really been faced with one particularly this challenging in my own practice, I'm looking at these and learning from them and taking pieces and saying, okay, what can I do to maybe not have these things play out? And there's the CBCT view of it. I've got some thoughts. Other struggles. Cost. $1,500 for a 3D custom MARPI with TADs included. And then we're getting these BMK screws and we're just using them as a default because they were part of the MSE offering from Great Lakes, but they strip. And on occasion, you'll hear about fracture. And then in order to avoid the stripping, you got to do a lot of pilot hole drilling. Then there's the big question of piezo. Did we need to do a cut at the anterior nasal spine or not? I think most people have backed away from that. And then, of course, like I mentioned, the old diastema, black triangle, the concept of expanding and then managing the space afterward. Well, serendipitously, the SuperTAD 2x14 and 2x17 smooth neck screw that was originally created for the infrazygomatic crest for completely opposite reasons has now become an amazing go-to for MARPI. As I studied that, looked at it, and started incorporating it into certain cases, I thought, well, gosh, once we don't need that mushroom head at all subtracting the mushroom head. We don't need that mushroom head at all to drive that into place. That is completely unnecessary. And if that was taken off ahead of time, gosh, we can just plan for these 2 millimeter diameter lumens with our 3D custom MARPIs. And of course, we got all this armamentarium that I've already been through, so I'll click through it again. But this becomes then also really helpful as we then talk about MARPI insertion, because that 25 millimeter blade and then that 35 millimeter contra angle driver is another word for it. The Taiwanese call it a blade for engine being the contra angle, blade being the tool that goes into it, but then the ratchet to finish off the insertions is golden, right? So, a collaboration was born, not for financial gain for myself, but because I'm right here in Utah and Cottonwood Lab and Brandon Farley is in Salt Lake City. They were already providing 3D metal caps for us, which we then fabricated our own in-house Hyrax expanders. I approached them and I said, look, I'd really love to introduce you to the folks in Taiwan. I think the BioRay mini screw system is a fantastic alternative to BMK screws for MARPIs. And so just, 15 months ago, that collaboration was forged. And now here we are with a full offering of 3D custom appliances supported by BioRay stainless steel screws. And what's cool is there is no proprietary software. There's the opportunity to have a planning session or avoid a planning session, either way. But you can just download the software for free. Blue Sky Bio is a free download. And what's really cool is you subtract away the maxilla, the mandible, and you just have that upper dentition with the palate. And you're looking at your screw placement. You can do this on your own and kind of get them where you think they need to be, and then ask for them to be refined. You can select a larger diameter screw of 4.26 millimeters that can be laid flat and orient that as a simulation for the tiger screw. relative to the mid-palatal suture and relative to the occlusal plane, so that you have complete control of it from the very beginning, or multiple steps along the way with synchronous planning or asynchronous planning in the form of DocuSign approval at the end. And so just multiple touch points along the way to orient the tiger screw correctly, either to follow the occlusal plane or to correct a cant. And so this marriage of the lab, the bioarray screws, and the software has now created this awesome change. So I have people ask all the time, well, what are your guidelines then yourself? And I'm drawing upon the information of my mentors about how to manage this. And so for me, I just want to look at the occlusal plane and say, is it pleasing to the smile, right? Is there a cant? And if there is a cant, do I want to change that? Early on, there was some recommendations to parallel the tiger screw to the infraorbital plane, and I don't really agree with that. I feel like we need to just look at each case individually. So this is a really good learning case where if you look at this gentleman's eyes, they're not on the same plane, nor is his infraorbital plane. But his smile has no cant. So there's been a certain amount of compensation or deviation from those two planes, but we don't really want to make the smile match the eyes. That would be a mistake. What we want to do is maintain a pleasing display. And so subjectively, I'm looking at saying, no, okay, we're going to make a MARPI for him because he's, in his 30s and on a CPAP and has crowding and has narrowness and really wants change to manage his malocclusion. But at the same time, we don't want to create a cant just because we're following the infraorbital rim with our tiger screw orientation in the lateral plane of space, right? You can see that deviation from occlusal plane to infraorbital plane on the CBCT. And instead, I'm going to go through this process of, I need 8 TADs, 4 anterior to the tiger screw and 2 lateral, 1 posterior to the tiger screw. Could have also placed those 2 10-millimeter posterior screws, could have gone between 6s and 7s. But I get the opportunity to see the orientation of the tiger screw relative to the occlusal plane, which is what I asked for. I'm not going to do a compensatory orientation for cant in this case. And interesting, you can see those anterior TADs show 9 millimeters of bone stock. Something to think about is the threaded portion of those 2x17 screws is only 10 millimeters. So that's about the limit you want to go without being extra cautious about the length. Maybe on a 10 millimeter bone stock insertion so that you don't go past that bone depth to chase bicortical anchorage with your 10 millimeter threaded portion of your 2x17, because it'll fracture right there at the junction of smooth and threaded. Instead, maybe you want to select a 2x17. So this is a 2x14, and just sacrifice that you're not going to have 9 millimeters of bone purchase and sacrifice bicortical, but you just don't want to try to put a TAD in there that doesn't have enough threaded portion to it to go all the way in, because if you try that, it's going to shear off. Ask me how I know, because we had that occur on another resident patient. Patient happens to be an orthodontic resident, now graduated at Roseman, right, where she had 10 millimeters of bone stock, and we actually lost we had 2 screw fractures that we had to retrieve, and everything was fine. We ended up just putting 2x14s in, and she had a beautiful expansion. Back to this case, though, this is the no diastema protocol, right? We get the initial split. This patient did have a piezo because he's over the age of 25. That's my personal protocol philosophy, following Ilya Lipkin with that. And now we pause, and the patient comes in, and we scan for aligners. We're going to make 5 to 5 upper aligners and 6 to 6 lower aligners, or 7 to 7 lower aligners. The no diastema protocol allows us to then control the diastema during the expansion, just as long as the aligners have 0.2 millimeters of dental expansion built into them to keep pace with 1 turn per week of the tiger screw after the initial split. And I'll review all that. That's the no diastema protocol. But these are images just shared with me today. All of my MARPI patients share images with me on Sundays. My phone gets flooded because I want to see their face in real time, week to week to week, and make sure that nobody's experiencing something unusual out there. I don't think we can be hyper vigilant enough with our MARPI caseload to prevent complications. The Austrians are the inventors of this amazing tiger screw device. It comes in all these different sizes that are actually interchangeable. So if you exhaust one, you can cut it out and put a new one in. But when you see that green stripe show up on that lower left photo, that's when you stop. And there's always a lot of talk about, well, what constitutes an activation, a turn, or a swing? And I think you just need to pick whoever speaker you're listening to and decide. So if you're listening to me, I'm going to tell you that the device literature states that 60 degrees of activation represents 0.17 millimeters of expansion, okay? And so 60 degrees is variable. Some patients can open 60 degrees, which is 3 fingers, or 40 millimeters. Others can't. They've also got this Great Lakes range of motion scale that you can use as your determinant. But if somebody has a very limited opening, they probably won't get 60 degrees per activation or per swing, if you want to call it, and therefore they might need more activations than the other person. But in general, 60 degrees is what the most adult patients that you're doing this for are going to need, or older adolescent kids, right? But somebody has limited opening, gosh, you might do the math and customize your approach for them. So Cottonwood Labs and BioRay and Blue Sky Bio, the pearls would be, we want to control stripping of TAD heads, control fracture of TADs, control cost of 3D custom MARPIs. Bundled together, there's tremendous savings. You don't even have to pay for shipping of the TADs or keep inventory. They just bundle it and send it with you with the 3D printed device. And then controlling tiger screw orientation from start to finish is really critical. Males over 25 get piezo. It's at the suture from the 6s to the 4s in the mid-palatal suture and about 3 millimeters deep. You can plan synchronously or asynchronously, and maybe keep your expansion goals at 6 to 8. I see all these 10 millimeter expansions and have to say, wow, do we really need that much? 6 is just a tremendous amount of nasal volume change, and it does manage most transverse discrepancies, not all, but most. And so sometimes I think we get excited about what we can do and we overdo it. Some of the expansions being shown probably are overdone, especially if they're requiring SFOT of the lower arch to match it. Maybe we don't need that much in the first place. So determine your range of opening at 60 degrees, 0.17 millimeters of expansion, and then customize if the range of opening is less. 6 swings for me is 1 millimeter. 0.17 times 6 equals 1. And that's if 60 degrees is achieved. 2 swings a week after that is the no diastema protocol. So you do 1 swing a day till you get a split. If you've customized the device correctly, you're going to do it. If you've done a piezo, you're going to get it without complications. And then thereafter, 2 swings a week, whether you're wearing aligners or whether you're in braces, that's all you need to get the change. Here's an awesome case shown by Dr. Audrey Yoon. And she gives me permission to share this case where this patient has a cant and an asymmetric mandible. And she oriented the tiger screw 1 degree for every 2 millimeters of vertical cant change. I think this case was only a 2 millimeter tiger screw orientation. And look at that amazing cant correction and how the chin point actually is not deviating to the left as much as it was before. It's now coming to the right. That is phenomenal to think that we can achieve that kind of change. So exciting that those things are possible. And of course, these huge nasal volume expansions and lower molar uprighting that's happening has become commonplace as people show their cases. And so kind of a guideline, 1 degree of tiger screw transverse orientation equals 2 millimeters of vertical change with a 6 to 8 millimeter expansion, right? So again, this is the hands-on course that's available the 11th. And finishing up with a few then management pearls. We're closing in on the end of our hour. TC rewards, base wage of 22. Natalie Parisi shared this in one of the groups a long time ago, and I loved it. And I said, yeah, that's perfect, because it's always so hard to motivate TCs to do all the extras, right? Get the same day start, to pull someone out of pending within 30 days of the exam, to take somebody that's been stagnant in observation and not keeping their observation appointments and re-enroll them, and a 6-year retainer plan add-on sale at exam, right? There's such a huge benefit to the patient to commit to that from the beginning. And when my TC does these things, she gets a $20 payout for each one of these things that happen. And that takes her wage to an average of $28 an hour. So on the Utah labor market, that's pretty strong for a person in a sales position. And it is commission-based, and it does fluctuate, but she has months where she makes well over $30 an hour for certain with the number of exams that we see. I love the Leanne Panici Snicker bar wrapped with a $20 bill, hiding somewhere in the office on a Thursday, and everybody goes and hunts for it like an Easter egg. Skill set of clinicians, borrowing from Dave Herman, I love the freshman JV varsity designations for my trained clinical assistants. We have a YouTube training library, we have mentoring, we have certificates, we have recognition, and as they reach those milestones, they get rewarded both with monetary gain and also wage. And as they achieve JV status, they have more autonomy in the clinic. And then, of course, at the varsity level, they start to behave like an orthodontic resident because they know the intricacies of treatment planning and chairside clinical decision making, and they achieve a much higher level of delegation and ease. And we're really proud that we have 4 or 5 varsity clinical assistants in on our team right now, and they are phenomenal. But we like to schedule them based on their skill set too. So in our scheduling designations, we'll have a soft column, which is retainer checks, observations that happen in the clinic rather than in a TC room. We have 2 varsity columns where that's where a simple MARPI insertion without piezo would go. That's where a TAD buccal shelf case would go. That's where a patient with special needs might go. That's where a patient that has high needs, right? They just need a lot of conversation and they need a lot of attentions to identify obstacles or limitations of treatment and accept certain compromises. And, I need someone there who can help communicate that and support what I say to the patient. Hey, this is just something we're going to have to accept. And if they hear it from another trusted voice, then we're all marching in step to taking braces off and feeling good about what we accomplished. Those are the varsity columns. We don't want to take a freshman and put them into a varsity column or have them try to perform at that same level. And the remainder of the team is first up. So we've done column assignments, and we've done first up as an overall team, and there was always hiccups and problems, but now we have this designated 2 varsity columns and a soft column. And when you're working 6 to 8 columns of patients per clinical day, depending upon day of week, whether there's 2 doctors working side by side, an individual doctor working alone, that's what we found to be successful. And so this is Tuesday morning of this week. You can see that first arrow on the far left of the morning, and the second arrow right there in the middle. Those are 2 varsity columns, and we've got some longer appointments. We have some D-bonds that require handpiece use, and varsity assistants have that designation. And then anything that's in purple is more of a soft procedure. We try to congregate those across. Pink is an observation appointment, so that 5th column over there would be the soft column. So 2 varsities are soft and the rest are first up. That has really worked for us as a team, and it's recent, just in the last year. We've put that in place, and it's really been accepted well, and I'm really excited about it because it's solved a lot of issues. Sometimes there's resentment that someone's not going as fast as they should, or maybe they're not in a first up system. They're avoiding certain procedures because they don't want to do them or they don't feel confident to do them. Doing this, scheduling for skill set has solved that problem for us significantly. Okay, I'm going to close with this. My good friend, Dr. Cam Quayle, is a pediatric dentist. We've worked in the community of Ogden, Utah. adjacent for many, many years. And in 2019, he invited us to go on a mission trip to Guatemala. And I hadn't done a lot of extractions or dentistry for a long time. I did a little bit while we were there, but ultimately what I needed to do was just make flippers. So I took everything that would do to make flippers: alginate, stone, denture teeth, pressure pot, a Dremel tool, and we brought in the local dentist, Guatemalan trained, and gave him all the acrylic and all the materials, and then trained him on how to do this and set teeth. And we had just a whole group of grateful little Guatemalan folks there with missing teeth, including young mothers like this, who would then walk out with a denture tooth on a flipper, feeling excited about being more confident to walk around the village and not be self-conscious about the space. And this, the sweetest, most grateful people, and so much fun. So if you're thinking about a mission trip as a orthodontist, maybe think about doing this. Dig out your lab skills and go to work and practice, and I highly recommend that. Thanks so much for your time today and being able to talk about all these different pearls. I'm happy to field questions from you. Look forward to talking to any of you. Have a great night and enjoy the month of December.